Hello and welcome to the second episode of our Blood Cancer Awareness Month podcast series on VJ Hemonc. This podcast is part of the Multiple Myeloma channel, which is supported by BMS and Legend Biotech. The podcast is intended for healthcare professionals only. In today's episode, we are joined by Dr. Rahul Banerjee, who shares his insights into financial and time toxicities in cancer care. Dr. Banerjee highlights the importance of addressing these toxicities and further explores his recent work in myeloma and how oncologists can better address these hidden burdens. Thank you so much for joining us today, Dr. Banerjee. Could you first explain how you define financial toxicity in the context of cancer care and let us know why it's important to address this topic?
Absolutely. Thanks for having me here. So financial toxicity, I think, is probably entering its second decade of life as a phenomenon in oncology across the breadth, not just in multiple myeloma. The idea is that financial toxicity refers to the out-of-pocket costs, the burden from financial costs from other things that patients are experiencing. I think, in the early days, people used to wonder, why call it a toxicity? Why not just call it something else? And I think it is a toxicity, right? Just like anything else, toxicity is something that impairs the ability of a patient to live their life to their fullest extent while they are receiving cancer treatment. And that can be neuropathy from bortezomib, that can be, rashes or GI issues from lenalidomide, or in this case, it can be financial toxicity coming from the cost of lenalidomide or the opportunity costs of missing work because they're coming in for infusions. So that's the easy part. The hard part, I'll just touch on it briefly, is that actually defining financial toxicity is devilishly difficult. Some studies have gone entirely the way of defining it just based on absolute numeric costs and just saying what is the out-of-pocket. That's a very American phenomenon, but across the world, patients are probably still paying something, even if it's not the cost of treatment, if it's the cost of parking, the cost of driving, the cost of your caregiver taking time off to work to drive you to your appointment and back. Those costs, that's one way to approach it. The other way to approach it is by surveying patients about the burden that it's placing on them in terms of, how sustainable is this? If you had to maintain this level of financial expenditures for the next 6 months, how would you feel? There is an inventory called a cost inventory, a patient-reported outcome that it allows you to kind of quantify what patients are going through. There's no clear cutoff. What is financial toxicity? What is toxic and what is not? It's difficult, as you can imagine, because it depends from person to person. So you would have to define what threshold you want to use. And then finally, one of my colleagues here at the Hutchinson Cancer Center in Seattle, Dr. Chris Su, is working on this idea of financial fragility. So not just the burden that patients reports, but are there objective measures of looking at that? For example, dipping into retirement funds early, declaring bankruptcy, skipping meals, skipping other needed things because of the costs of care. So again, in summary, the concept is pretty easy, very intuitive that just about anyone will understand, financial toxicity. The hard part is defining it, but I think with every year that passes, we're getting better at trying to define it.
Thank you so much for that. You've also covered a concept known as time toxicity. Can you explain how this differs from financial toxicity and how these burdens go hand in hand?
Absolutely. So I think if financial toxicity is kind of a teenager now in terms of how old it is, the toxicity kind of really was first conceptualized 10, 20 years ago. Time toxicity is all in the last 10 years as a defined entity. So time toxicity is pretty similar conceptually. So instead of the financial burden of costs from financial toxicity, it is the time burden of costs, of the time burden of therapy and the impairment and the issues with patients' quality of life or ability to live their life that entail from that. Also very tricky to define. Obviously, some parts of it are intuitive, right? So a transplant or CAR T therapy are very time toxic, so to speak, in the initial period, right? The people are often in the hospital, a lot of toxicities, even if they're not in the hospital, they're coming into clinic every day for evaluation. That's the easy part. The harder part is defining time toxicity in other spheres of myeloma, right? So during induction or during maintenance treatment, et cetera. And we'll talk about, I'm sure, next some of our research into this space, but the same principle applies, right? It's easy to define, but in terms of how to actually measure it is tricky. Some researchers have really gone the way of just pure number of hours or number of days in a healthcare setting. Purely that, nothing more, nothing less. The nice thing about that is it's quite objective, right? It's just, in a given year, these patients spent at least 95 days out of the year in a healthcare setting, either hospital, clinic, etc. Others have tried to do the same principle of surveying patients, interviewing patients to understand, what actually the burden is of time toxicity. The hard part is that it's very tricky because it depends from person to person. Some people, for example, I've had patients who are, retired and they actually like coming into clinic. And for them, an extra time driving into clinic and spending time with the nurses and other patients is not toxic to them at all. But for someone else who's working and is themselves a caregiver for a family member, for a child, for their own spouse, that same amount of time can be incredibly toxic to them. And there are other nuances to it. Even if you could calculate the number of hours spent in clinic, I have had patients who, as an example, bortezomib and carfilzomib, just to make this myeloma specific, both are proteasome inhibitors. Bortezomib is given often subcutaneously, carfilzomib given intravenously. So there's some more time toxicity to an intravenous infusion versus sub-Q. But even the schedule of the days. So in the trials, bortezomib is often dosed days 1, 4, 8, and 11. So Monday, Thursday, Monday, Thursday. Again, I don't agree with that. I believe in once weekly proteasome inhibitors. Story for another day. But if you're going by the book, the trial is Monday, Thursday for bortezomib. For carfilzomib, it's days 1, 2, 8, 9, 15, 16. So it's Monday, Tuesday, Monday, Tuesday, Monday, Tuesday. Same number of days, even if they were the same amount of time in clinic, let's say carfilzomib was subcutaneous, I've had patients who tell me that the back-to-back days are actually more time toxic because they're working, or they work as rideshare drivers, they work, odd hours, and taking 2 back-to-back days off for healthcare reasons is much more burdensome to them and to their workplace and to their coworkers than splitting it to Monday, Thursday, Monday, Thursday. The reason I'm giving that analogy is very specific, but it's a good example of how difficult it is to define time toxicity because it really depends from person to person, even during phases of therapy. People are trying, and we'll talk about that. I think the bottom line, I would say, is that, even if you cannot fully quantify time toxicity for patients, I think any steps you can do to minimize time in clinic while maintaining efficacy and safety are very reasonable. And I'm sure we'll talk about that, but bispecific antibodies are a good arena for where people have explored that. Even where we haven't yet come up with a good patient-reported outcome measure to objectively measure time toxicity, the fact that all these trials are going, you're jumping over each other to say, look, I'm going to go from once a week to once every 2 weeks, or I'm going to go every 4 weeks, or I'm going to go every 12 weeks, et cetera, is great. Because even if you can't objectively measure the impact of that on patients, you know that it's having an impact because people don't have to be in clinic and they're in remission, they're able to live their life.
Lovely. Thank you for that insight. Moving on, would you also like to highlight any specific work that you've done in the space, specifically relating to patients with multiple myeloma?
Yeah, absolutely. So thank you for highlighting our work. So it was published last year in CLML. The journal is open access as of last month, actually. So it's open for anyone to see. And it was a survey of financial toxicity and time toxicity among transplant recipients and transplant survivors at our center. So hundreds of patients at our center. We are a large transplant center in the United States. And every year we ask our survivors of transplant to say, would you kindly fill out a survey to just understand, how you're feeling and different topics that come up. We always ask for quality of life. But this year we asked about financial toxicity measured using that cost inventory I discussed earlier, and time toxicity using a kind of homegrown instrument that we came up with using patient input from the patient support group, the Myeloma Fighters, that's their name, the support group in the Seattle area, came up with a survey to ask patients about, how much time are you spending in clinic? How much time are you spending on the phone? How burdensome is this for you? And questions like that. And in brief, just at a high level, our goals were to just explore predictors of financial toxicity, predictors of time toxicity, and then kind of explore the interplay between them. And so some things were unsurprising. So unsurprisingly, lower household income was associated with higher financial toxicity. Higher monthly out-of-pocket costs was associated with higher financial toxicity. Again, that's not so surprising in itself. It's unfortunate, but yes, unfortunately, money does help, especially in the United States, the way that our healthcare system is set up, and patients who do not have as much disposable income, things are a bit trickier for them, for sure. We did find that the higher someone's financial toxicity was, the lower their mental health was in terms of their mental quality of life as measured by the PROMIS 10 instrument. A lot of caveats we can go into there. There may be some confounders driving into it because it may be that the patients who have less disposable income are more likely to have financial toxicity, but are also working more and, having to do more odds and ends jobs to maintain that income. And so they have more depressed quality of life as a result. But that's one thing. In terms of time toxicity, we found that, going back one step, I'm sorry, for financial toxicity, one thing that we found quite interesting was that financial toxicity percentages and the distributions of cost scores were fairly consistent based on patients' phases of therapy. So again, these are all patients who have undergone transplants. We didn't include any newly diagnosed patients. There are separate studies of that I could talk about separately. But at least in the long-term sphere, whether you were in remission or whether you had relapsed myeloma, and or if you were remission on lenalidomide maintenance versus remission after CAR T therapy, years after transplant and not on any therapy, financial toxicity was roughly stable between them. A little bit surprising. You might have guessed that patients who have active myeloma would have more financial toxicity than those who are in remission. And the answer was no, not at least in our data set. And we could talk about the implications of that, but I think it's important. I think a lot of that is lenalidomide is very financially toxic, and that's a problem for patients. Time toxicity, about a third of patients overall reported some level of time toxicity. It was obviously higher for the patients who have relapsed myeloma, and that's okay, and that's understandable. Most patients, if you ask them, once they have relapsed myeloma, many of them are willing and find increased time in clinic quite tolerable to, go into clinic, go into the hospital, get back into remission, etc. But about 30% of patients who were in remission were also reporting time toxicity by that particular inventory. We define time toxicity as an interaction at least once a week, either by phone or in person with a clinic of some type, or for patients who live far away from clinic, at least once a month where they're driving at least 4 hours in the clinic or back. Why does that matter? I think that's high, right? The fact that patients in remission, a third of them almost are reporting time toxicity. You might wonder, well, why is that? And I think the big reason for that is because we included phone calls. We specifically asked, what about phone calls? How often are you calling or messaging or something related to your myeloma care? And that is a profoundly high number that people are being asked to do that. Some of that may be a America-only phenomenon, but I think a lot of it is a global phenomenon. Anyone on lenalidomide maintenance, most countries have restrictions around lenalidomide because of the historical risk with the different drug, thalidomide, of birth defects. A lot of restrictions on how you prescribe it. Testing for pregnancy. You always have to prescribe a limited amount at a time, etc. People are often on the phone calling for that. In America, we have this unique issue because of the REMS requirement, which is this, series of checks and balances to make sure that people aren't getting pregnant while they're on it. I would say it's kind of overbearing for most of my patients. But partly because of that, and because of the cost of lenalidomide in the United States, some pharmacies require that the prescription be mailed to your house, the patient's house. You cannot pick it up at your cancer center's pharmacy. It has to be mailed to you. That sounds like a great idea, right? It sounds like there's less time toxicity, but it's actually the reverse, right? I didn't realize this while doing this research because in the vast majority of those cases, a signature is required for the courier service to be able to drop off a lenalidomide at your house. We have patients who tell me that it's actually a curse because that means that once a month, they're trapped in their house for the whole day. They have to wait at any moment. The truck can come with the courier service to drop off the lenalidomide. If they're not there, then they're going to miss their cancer pills and they're going to fall behind. So it's tricky. That's a good example of how it's very difficult. Unless you ask about this kind of stuff, you don't learn about it. And I have learned a lot from asking about it. There's work to be done. So I think, our survey wasn't necessarily, solutions oriented, right? We weren't able to find any hot topics on how to reduce this, but I think we can talk about that next. I think for financial toxicity, recognizing it, I think is step number one. There was an ASH abstract a couple of years ago that looked at a randomized trial of randomizing patients in the United States to get a financial navigator versus not. It actually didn't show that much benefit compared to just giving people handouts. It turns out that just educating people about options available to them to lower their copays or empowering them to ask their doctors, hey, do I really need this medication or can I go on a lower dose, etc., goes a long way, whether you have a financial navigator or not. But for vulnerable patients, definitely having resources available goes a long way for them. And then for time toxicity, we did find some correlations between caregiver status and time toxicity. Ironically, those who had a caregiver reported more time toxicity, probably because they were also trying to care for their caregiver, or they themselves were also caregivers for someone else, like an elderly parent or a child, etc. and just being cognizant of that and recognizing that's a problem and finding ways to minimize that are helpful. I think a silver lining of the COVID-19 pandemic has been that telehealth is here to stay across the world, not just in the United States. People are using it more, and getting more comfortable with using it, both physicians and patients, right? A physician, I was always comfortable with it, but a lot of patients were kind of, they wanted to see the doctor in person. Now, a lot of them are totally fine seeing them with telehealth, which is fine. Even for a person who's coming in once a week for clinic visits, for example, and blood work, I've also found that sometimes fragmenting, separating the visit with me away from their blood work actually is less time toxicity than putting them together, believe it or not. The reason is because if you do your blood work in person, you don't have to wait for the blood work to result before the doctor can see you, before you can get treatment, etc. So if you break things apart and do some parts by telehealth from your home, you actually are lowering the amount of time spent just waiting for blood work to result. And so a lot of cool tricks that we're learning about from our patients and from just experimenting.
Thank you for sharing that. That was very interesting. Lastly, what advice would you give to oncologists, especially those working in the community setting, to better address these toxicities with their patients?
So I would say ask about it in both directions. So, because I have been guilty, you can imagine just with the enthusiasm I'm projecting here that I love lowering time in clinic. And for most patients, they appreciate that. I will say there have been some times where I've asked and been like, look, you don't need to see me anymore. You can see me once a month by telehealth. And some patients do prefer to be seen more often in person. If it's reasonable, it's reasonable because every patient is different. So I think the bottom line is ask your patient about time toxicity and preferences. Most patients would prefer to spend less time in your clinic and not more than that. So I think my suggestion would be to be practical and be flexible about it. I think, seeing that, hey, can this patient get blood work closer to home? Do they need to get blood work every single month? Can it be split up? Do they need to see me every month? Can some of the visits with me be telehealth if nothing else is going on? Because again, even if you still need to see a patient once a month, there is less time toxicity with telehealth as opposed to not. So those are the kind of low-hanging fruit ways to lower time toxicity. Bigger things would be, bispecific antibodies are coming for everybody. I would say that finding ways to operationalize outpatient bispecific step-up dosing, it's happening. Bit by bit, our center has moved exclusively to outpatient unless someone has comorbidities or something else going on that requires inpatient step-up dosing. Things like that will go a long way for patients and actually might steer more patients towards doing it. In the early days of bispecific antibody therapy, where we were saying we have to hospitalize patients for up to 2 weeks for step-up dosing, some patients would just say, no, they don't want to do that. But if you're like, look, we're going to start outpatient. If you get a toxicity, like cytokine release syndrome, you have to go inpatient to get that. But if they don't have to, try outpatient. I think they really appreciated that. And I've had some patients who were kind of on the fence about doing it, but having an outpatient option because of lower time toxicity and less time in the hospital worked out for them. For financial toxicity, I think the biggest thing is, again, ask your patients and refer them to social workers at your institution liberally to help with things. I have been pleasantly surprised by what our social workers are capable of doing. They have moved mountains to help our patients out in terms of other copay assistance programs in the United States. Other societies often offer grants to help out with things, helping out with disability for caregivers. We've had patients who, their caregiver is the one who is employed and is trying to take care of them while trying to work. And the social worker has found very creative solutions to work with them, or even written a letter saying, look, this person needs part-time accommodations or needs temporary leave of absence, or can they work from home and still fulfill their duties? And that letter from a social worker with the cancer center stamp on it goes a long way. It's hard because obviously doctors, have limited time in clinic. I say that, but my partners in the community are seeing even more patients, way more patients with myeloma often or other blood cancers than I am. And it's hard. So I think, operationalizing ways for patient-reported outcome surveys to do this, or medical assistants to ask about it, or the nurses to ask about it, or have the social workers screen everybody when they're after a couple of months of treatment, I think will go a long way. Because I think patients don't think that they can even talk about this. They just assume that it's something that they have to do. And many of them don't know that they can find resources online to help with this. So I think education from us, even if we can't solve the problem directly, if we can connect them to people who can help them solve problems financially, I think that's a great idea.
Thank you so much for tuning in and listening to Dr. Banerjee's insights. We hope you enjoyed today's episode. Please stay tuned for the next episode of our Blood Cancer Awareness Month series, and be sure to follow us on X @VJHemonk, as well as on Spotify, Apple, and Podbean. Until next time.